Hey guys, this is a continuation of AOGD March 2025 bulletin. So this is a labor care guidelines. We already know WHO introduced labor care guidelines. So just I'll give a history. So in last 2 decades, almost 20 years onwards, there is increase in induction augmentation and preterm termination of uncomplicated pregnancy. Okay, so first partograph was given by WHO in 1988 and it was updated in 1994. Okay, in first partograph, the cervical dilatation for active phase it was taken as 3 centimeter. Later, because of early interventions and more cesarean sections, they modified the WHO partograph and made active phase starting from 4 centimeter. Okay, so they made a simplified partograph which giving a red color for active like action line is red. If the action line is red, then that indicates it is a dangerously slow labor progress, then you should go for intervention in that way. After trials and errors, finally they've settled with the WHO labor care guidelines, which was introduced in February 2018 by WHO. Okay, this has many different changes, and it is the evidence-based practices is the principle followed in labor care guidelines. So I'll tell about labor care guideline advantages over other partograph. Okay, first thing here, the active phase rises by 5 centimeter. How much? 5 centimeter. So this remains premature designation of active phase of labor. So see, 4 centimeter if you give, there is high chance of intervention. So that's why they changed to 5 centimeter. Even the thing like 1 centimeter per hour should be increased. This also been changed. Okay, depends upon the female. Second is maternal and fetal monitoring. Second stage of labor is a critical time for the fetus because of uterine activities increase and there is this can lead to fetal hypoxia. So fetal and mother should be monitored in the second stage of labor. And after recording all that, will plan according to the assessment and discuss with the woman. Okay. Then respectful maternity care should be given. So supportive care should be allowed and labor care guidelines focus on action-oriented labor monitoring. Okay, this labor care guideline is a tool that rather than any record. It's a tool. By using that, we can tell what to do, what not to do. It's a tool. So what is the aim of this labor care guideline? It is like it's helpful to monitor well-being of women, the fetus, even the progress of labor. Supportive care is allowed. The assistant health professionals need to recognize this is the emergency situation and they need to do intervention. Okay, it prevents unnecessary intervention. And for audit also, this labor care guideline will be useful. So why they did surgery, we can show the labor care guidelines in that way. Okay, and labor care guidelines can be used in all, irrespective of high risk, low risk. Everyone can be using this. Okay, so after 5 centimeters of cervical dilatation, we'll start the labor care guideline graph, and all levels of deliveries can be used, like primary, secondary levels. Even small PHC people also can use labor care guidelines. Only thing they should know how to use. Okay, there are 4 points in labor care guidance. That is ARCP. Okay, A is assessment. You'll assess the condition of the patient in the fetus and also the progress of labor. Then you'll record everything, whatever you assessed. Then you'll check. You'll check means you'll have a alert, a red line zone, red flag areas. You will compare with that, and if there is red flag, then you can write alert in check column. Then you will plan. So if there is alert lines, alert conditions, then you'll plan what to do next. That is the thing. Okay. So so 5 centimeter is the active phase beginning, and 1 centimeter part thing also they have removed. Recording the plan of management important supportive care should be given, and aim is to give the you should follow the well-being of mother, fetus, and also progress of labor. And there is ARCP assess check assess, record, check, and plan the management. So first thing is time axis. In time axis, there are two zones, time and hour zone. Here you'll write 130, 230 in that way, and you'll say 130, 230 is 1 hour, 2 hours, 3 hours in that way. Okay. Even second stage also you will monitor like this. So uh, so these are different sections of 7 sections of labor care guidelines. One is you'll identify the woman. For example, name of the woman like Mary. Okay, you'll identify the women and labor characteristics. So these are different things, like you'll identify the woman and parity, first pregnancy or not, the labor onset, all the labor points, labor onset, active labor, diagnosis, rupture of membrane, risk factor. Okay. One important point is there is no age in this section. Okay. So identifying information, you have only name and parity. Then you have labor onset, active labor, rupture of membrane, risk factors and all. There is no age. Okay. Age, gestational age like 36 weeks, 2 days in that way. These are also not there. So age, gestational age, um, referral status. Okay, these are all maintained in her own medical record file. In labor care guidelines, only the name and parity and others are all labor process thing. Supportive care should be given. No, supportive care means not only companion. You should give pain relief. You should give oral fluids. Okay, posture also should be taken. If she is agreeing, it is Y. If it is she is denying, it is known as N. Okay, care of the baby once the baby is like fetal heart not during labor. Care of the baby should be taken. Fetal heart should be oscillating minimum for 1 minute. How much? 1 minute. Even amniotic fluid membrane status also comes under baby. You have fetal position, cap put, and molding. Okay. Then see, this is the basal heart rate of the baby. See, if it is less than 110 or more than 160, it is alert. Fetal deceleration should be taken. Fetal position, caput, succeedum, and molding. Care of the mother, all parameters should be assessed 4 hours or less, otherwise indicated. Proteinuria, estrogenuria can be monitored. Labor progress for at least 10 minutes should be taken. Okay, and every 4 hours cervical dilatation is taken. It is measured as X. P is for pushing in the second in the like in second stage, P is pushing is written, and O is for cervical descent. So we'll see a graph here. See, contractions are written 3 here. 3 means 3 times the contractions are there, and it is lasting for duration is 50 seconds. And if you see cervical dilation, it is 5 centimeter. We started here, and it is 8. Again, it became 10 fully. The descent also it is +4, then it is +3, then it became +2 at full dilatation. In that way, okay, we can monitor that. Medications also, if oxytocin or any other medications, then we'll mention that. Even IV fluids also, if it is present, yes or no, you'll write that. Okay. So these are things like we'll the fetal membranes, fetal heart rate, fetal membranes, fetal position, caput succedum, and care of the mother. Labor progress should be maintained like cervical uterine contraction, cervical dilatation, and descent of the head. Even medications, if used, what is the medication and how much amount it is used should be written. Shared decision making should be taken, and this is the labor care guidelines. If we see, okay, first there are 7 sections. I told 7 sections. So this is first section. Uh, so this is first section. So you have name, parity, labor onset, active labor diagnosis and date, rupture of membrane, any risk factors should be written. Okay. So next is you have supportive care like age, time, sorry, companion, pain relief, oral fluids, and posture. Then you have baby, then you have mother. Baby, you have heart rate, amniotic fluid, fetal position, and caput. Mother, you have pulse rate, BP, temperature, urine. Then you have contractions. Okay, labor process, cervical tension, and descent. Then medications, oxytocin medicines, or any IV fluids. Then you'll assess and plan. Okay, these are the things. And if you see this mainly this is the important thing, because second stage of labor is not there in previous partograph. So second stage of labor is very important here. Okay, you have 3 columns. This is active labor diagnosis date. Okay, that's it. Okay, so these are different parts. These are different sections of labor care guidelines, and these to be noted. Okay. Conclusion is healthcare providers should be given ample time for understanding the labor care guidelines. Okay, that's about labor care guidelines. Next topic is CTG. Okay, CTG is like a controversial topic. Okay, because as there is interabsorbable variability, there are different conditions where interventions are taken. Okay, so almost 40% of stillbirths occur during labor, so CTG helpful to see that. But because of this, there is increase of number of cesarean section. Okay. Um, CTG was introduced in 1960s. In fact, before partograph, CTGs were introduced. FHR in conjugation with the contractions it is monitored. We'll see four variables like baseline heart rate, variability, accelerations, and decelerations. FHR is actually controlled by sympathetic and parasympathetic system. So after monitoring every thing, then we'll categorize CTG traces as normal, suspicious, and pathological. Okay. So CTG was introduced in 1960. Okay. So baseline variabilities and accelerations and decelerations are same. So ACOG only we'll learn about ACOG. Heart rate is 110 to 160 and variability 6 to 25. You have early decelerations as normal, whereas the category 1 or 3 not resting like if it is 161 to 180 or bradycardia or variabilities are absent. Okay, like see pathological means if there is absent variability or if there is late variable deceleration, sinusoidal pattern, it is pathological. Okay, so NICE recommends that hourly assessment should be taken into consultation. Suspicious if it is there, then you can go for metal position change, IV fluids. Okay, if there is contraction, then you stop the oxytocin and uh, no role of oxygen supplementation amino infusion. There is no role. Only we'll follow that if there is bradycardia, will give oxygen supplementation, but there is no role of amino infusion or oxygen supplementation. Okay. So fallacies of CTG is almost 95% of pathological CTGs are same, but there is no difference of cerebral palsy between pathological CTG born child and normal child. Okay, the incidence is same, 1 to 2 per thousand. CTG was introduced without any trails, so that was one of the fallacy. And there is inter and intra-absorbal variability, which I already told. Okay, um, so these things. So newer approaches because of these differences in observation, computerized CTG was came. It reduces the interabsorbable inconsistency. Um, there is a new guideline developed by experts. It is known as International Consensus Guidelines. It is based on fetal hypoxia and fetal stress response. Like if there is no hypoxia, chronic hypoxia, gradually evolving hypoxia, subacute hypoxia, acute hypoxia, chorioamnitis, and these things. Like you on CTG, you can see abnormal findings like double mount peak sign, typical sinusoidal pattern, uncertain and unstable baseline. So you should see that if there is any changes in CTG, you should enter what are the changes you have given to the mother. Like if you're giving tocolytics, like magnesium sulfate. So many people give magnesium sulfate for neuroprotection and followed by they'll do CTG. On CTG, they'll see baseline heart rate is reduced, variability is reduced, and they'll do cesarean section. Okay, this should be avoided because magnesium sulfate is causing the CTG effect. So within 1 hour after stopping the magnesium sulfate, it will be reversible. We should monitor the fetal response. Even then, if it is not recovering, then go for cesarean section. Okay, so this kind. Even some people will be using nifedipine for as a tocolytic. Okay, in this mild fetal tachycardia can be seen. You should monitor the mother that way. Okay, most commonly used drug is oxytocin. If you are doing oxytocin use, then there is late deceleration seen. Okay, if you are having hyperstimulation, then stop the infusion and wait and see. Don't go for cesarean directly. Okay, even the dinoprostrone gel which we are using every day and all, uterine contractivity will be increased and there is possible fetal distress. You should monitor the contractions and go for cesarean section. Corticosteroids reduce the variability. Analgesics reduce variability. Even after giving epidural, there is fetal bradycardia. General anesthesia less for FHR. Okay. Anti-epileptics like benzodiazepines decrease the variability. Even antibiotics have less effect. Whereas if there is maternal fever, there is increased baseline FHR. Okay, tachycardia is seen. You should administer IV fluids and antibiotics to the mother. Okay. Meconium stain liquor also there is variable deceleration. Continuous CTG should be done. If fetal stress distress is expressed, then expect the delivery in that way. So you should monitor what drugs are being given, like magnesium sulfate or prostaglandins. Then you should monitor it and then prefer for cesarean section, not directly going for cesarean section on the basis of CTG value. Okay. So that new terminologies and concepts been given, like two types of deceleration seen, that is quickly and tardy. Okay, quickly is something like there is deceleration and quickly it comes to the baseline. Tardy is there is slow deceleration and slowly it comes to the baseline. That is tardy. Okay, quickly indicates that is the cord compression, whereas tardily indicates because of uteroplacental insufficiency. There is one more pattern is zigzag pattern, which is a rapid hypoxia it indicates. Okay, so the cases of rapidly evolving hypoxia and there is exaggerated autonomic nervous system. There is up and down fluctuations in the basal FHR. So it results in zigzag pattern. It lasts for over 2 minutes. There is 11-fold increase in neonatal unit admissions. If there is zigzag pattern, that is 11 times the unit can admit. One more term is SOFI. SOFI is suggestive of fetal inflammation. So there are 10% increase in fetal deceleration and basal FHR more than 10%. See, for this decision, for example, 38 weeks, the basal heart rate should be like this. At some, remember, for example, if it is less is than 110, then if it is more than 10% of higher than the baseline heart rate, then it is a sign of fetal distress. Okay, it's a sign suggestive of fetal inflammation. That is being done, and CTG has significantly higher levels of interleukin 6. What interleukin 6 is high in the umbilical artery, which is linked to the increased neonatal admissions. Okay. One more term is RUPI L. RUPI is L is relative uteroplacental insufficiency. Um, this phenomena because of imbalance between placental supply and fetal demand. Okay. So there is because placental dysfunction, subtle dysfunction is seen as the contraction decreases the intensity and frequency, the dysfunction disappears. Okay, that is related to uteroplacental insufficiency of labor. That's it. So excessive oxygen administration also it causes vasospasm of the placental arterioles and increase the risk of fetal hypoxia and acidosis. Okay, you understood? So these are different terms being used nowadays. Quickly, which is cord compression, and tardy, which is of uteroplacental insufficiency. Zigzag pattern indicates that is fetal distress. There is SOFI, that is a fetal inflammation. Okay, 10% rise in basal heart rate. Then interleukin 6 is seen in rise in umbilical artery. 2P is related to uteroplacental insufficiency of labor. And certain circumstances also you can see that oxytocin have hyperstimulation conditions. Okay. So pyrexia and acidosis have cumulative effect on neonatal encephalopathy. So antibiotics and antibiotics should be given. And major abruption tocolytics may agree with hypoxia by enhancing the placental separation. Epidural analgesia has acute hypoxia, which is reversible with IV fluids and ephedrine can be given for acute hypoxia. Okay. Prematurity also. See, generally in term we'll say 15 beats for 15 seconds now, but premature you'll say 10 beats for 10 seconds. There's immature CNS, and that also indicates there is uh, decelerations are present. Okay, fetal blood scalp blood sampling is used to be done. There is a trail known as Flamingo trail where they say that accuracy of CTG monitoring versus combining with the lactate level, then the efficacy of fetal blood sampling has been failed. So they say that fetal blood sampling is not that important. Nowadays there is digital fetal scalp sampling. That is, you with the fingers, if you if you press the head, there is a uh, 5 to 10 minutes, and there is likelihood of low scalp pH of only 2%. I didn't get wait. An acceleration, yeah. After pressing the head, there is acceleration of 15 beats for 15 seconds. Okay. Uh, it indicates that the likelihood of low pH is only 2%. If the fetus is reacting, then it is good. Okay. Mm, and another term is STAN analyzer, that is ST form analyzer. This has been shown that in fetal hypoxic changes, there are changes in fetal echocardiography. Okay, because ST elevation is caused because of catecholamines released in the fetus. STAN has disadvantages also because it need training, it need observation and all. So conclusion is as stillbirths have psychological effect, so proper monitoring is very important. Fetal surveillance can be used by means of can be done by means of CTG. Okay. Um, International guidelines recommends classifying CTG tests based on fetal hypoxia and stress responses. Okay, these are the things. So pyrexia can result in NA, in neonatal encephalopathy, and Trail says that there is no advantages of using fetal blood, acidosis and all. Okay, that's about this topic, fetal cardiotopography. Last topic is very interesting one, that is intrapartum ultrasonography. Okay, see, intrapartum ultrasonography is nothing but during labor, you'll do ultrasound and you'll see how is the fetus position and all, whether vaginal delivery is possible or not. Okay, so this can avoid the decision of a cesarean section, or you can do like instrumental delivery also you can take. So it avoids unnecessary intervention. Okay, so this ultrasound during labor is known as sonotomy of maternal pelvis. It helpful to find out how is the fetal head in respect to pelvis. So indication of this ultrasound evaluations, like, so for example, a lady came, she's progressing well. After some 4 hours, if you did PV and the head is being chronic. And for these patients, there is no need of doing ultrasound evaluation. So if they're having slow progress on first stage labor or slow progress in second stage of labor, and you can find how is the fetal head position station. Okay, if there is any fetal head malpresentation, you can assess that. Okay, so the usual probe, that is 3 to 5 hertz, hertz probe is used. There are two probes, transabdominal and transperineal measurements can be used. And while using the transperineal one, we'll take a cover on the probe and we'll take jelly inside the cover and outside the cell cover to minimize the air gaps. Okay. First is we'll assess the fetal head position. So this is the perineum. This is the perineum of the mother. We'll keep a probe on this. Okay. So the lie of the fetus and position of the occiput can be described here. So from the perineum, and you will see the head. So from the perineum to the head is known as HPD, that is head perineal distance. So head perineal distance is measured from frontal transperineal scan as shortest distance from the open bony limit of fetal skull to the perineum. So what is the bony limit to the fetal perineum is known as head to perineum distance. Okay, they used to say that if the head is at zero station, then the HPD, that is head perineal distance, will be 35 to 36 mm. If it is 38 mm, then it can be mid cavity. 38 mm is mid cavity. Okay, so why the intrapartum ultrasound is required to find out if there is any slow progress or if there is any slow station. What is the station? What is the fetal head position and all? We'll use a normal 3 to 5 hertz ultrasound probe, and we'll keep on the perineum and we'll see from the outermost fetal skull to the perineum, and we'll measure the distance. Is generally said that 35 to 36 mm of head back to perineal distance is the station, and 38 mm indicates it's the mid cavity position. Okay. Next, next is fetal head direction. Fetal head direction is the angle between the longest recognizable thing. Like there are different angles, fetal head direction. For example, it is an angle between the longest recognizable axis of fetal head to the longest axis of pubic symphysis. So, for example, this is pubic symphysis and this is fetal head. So, this is the long axis of the pubic symphysis and this is the long axis of fetal head. So, the angle between these two is known as fetal head direction. Okay. Uh, if the head is down, the angle will be less than 0. If head is horizontal, 0 to 30. If head is up, it is more than 30. Once the direction is upwards, head up, one can predict that there is easy extraction. Okay. If the angle between these two is more than 30, it indicates easy extraction. It's about fetal head direction. Other angles are fetal head descent. So how to assess the fetal head descent, whether it is progressing, coming down or not? That is known as angle of progression. So this is the angle of progression, or it's also known as angle of descent. Descent. It is the angle between the long axis of pubic bone. So this is the long axis of pubic bone, and line from the lowest edge of pubis drawn tangential to deepest bony point of fetal skull. So tangentially, you'll draw a line. Okay. So this is pubic symphysis. You'll draw the long axis and there is a fetal skull, you'll draw a tangential line. So this angle is known as angle of progression. Okay, long axis of fetal head to fetal line, it is known as fetal head direction angle, whereas angle of progression is this tangential line. This is a short learning curve. Generally, the angle of progression has extensively studied, and it has said that if angle of progression is 116 degrees, it corresponds to the head of station 0. So, if angle of progression is 160, it corresponds to angle of head station of 0 station. The head is on 0 station. Okay. Next is midline angle. If you see midline angle, it is measured in the axial plane transperineally. This angle is formed by echogenic line interspersed between two cerebral hemispheres and anterior posterior direction of the maternal pelvis. Okay. So here, this is the two hemispheres between line, and this is AP axis of maternal pelvis. So angle between these two is midline angle. Okay, midline angle is very important. I felt that midline angle is very important to find out the indicator of progression. If the fetal head is rotated properly, if the AP diameter of the fetal and the maternal pelvis is corresponding, then there is more chance of vaginal delivery. So rotation is good. So this rotation is indicated by midline angle. Okay, midline angle is less than 45, then the station if indicates that it is +3, and thus it is a predictive of successful vaginal delivery. So see, so midline angle should be less than 45. That indicates it's a good uh, direction, like rotation has been happening. So how to report the intrapartum sonogram? See, intrapartum sonogram also you will say whether the fetus is single, presentation, fetal heart rate and present position. Apart from this, you should say that whether it is occiput is in the anterior or uh, sinciput is in the anterior, and also the spine position is uh, commented. So different angles which are seen is angle of progression, head perineal distance, direction of fetal head corresponding to the pubic symphysis, and midline angle. Okay, even though you're doing all this, you should follow the PCP90 rules. Okay, these are different angles. I'll just repeat the angles one more time. So I told already the head perineal distance. This is easy, but fetal head direction should be measured. Like it is a long axis of fetal head to the long axis of pubic symphysis is measured, and if it is head up, then it is good time for delivery. And assessment of progression angle AOP, it's a angle extensively. If it is 116, then it's correspond to station 0. That means the fetus can occur. It's a tangential line. Okay, from the long axis of pubic symphysis, it is a tangential line. Next is midline angle. It indicates the two hemisphere line and the long axis of maternal pelvis. And we will see the line. If it is less than 45, that indicates +3 station. Okay. These are different distances and different angles which are measured during intrapartum ultrasonography. Okay. That's it. Thank you.